About this time, I had developed, as a result of a chance observation back in 1956 or thereabouts, I saw this patient who came to see me. He'd had back pain, buttock pain and pain down the back of his thigh for 3 weeks. And he was not improving. In fact, he was getting worse. And this is in the days ultrasound had just become it just been introduced, and we didn't know whether it was good or bad, so we all got it anyway. We were using ultrasound, and we're still using shortwave diathermy in 1956. This patient came in, and I told him, Mr. Smith, go into that room. When that man comes out of that room, go in there and lie face down on the table. Now the back of the table had been raised for a man to lean against the back of the table while he was having his knee treated. Probably having shortwave crap and stuff like that. And I said, when he comes out, you go and lie face down on the table. Mr. Smith wasn't all that bright. And he went in and lay down, face down, on this table with the back raised, and it put him into extreme hyperextension. And after about 5 minutes, I thought I'd better go and see this fellow. And I walked in the door, and here was Mr. Smith, lying in hyperextension with a back pain and leg pain. And I thought, my God, what are the consequences of this going to be? How are you feeling, Mr. Smith? Mr. Smith says, this is the best I've been in 3 weeks. And I thought for a minute, good, oh, in what way are you better? All the pain's gone out of my leg, it feels great, he says. It's increased in my back, it's right in the middle of my back, hurting like hell in my back. But he says, I can put up with that, it's the pain in the leg that gets me. It's all gone. Oh, that's good, that's good. Well, look, that's probably long enough in that position. Come back and we'll do it again tomorrow. Mr. Smith stood up, and I said, what's it like? And he said, it's gone out of my leg. I said, oh, that's good, we'll do it again tomorrow. So he came in the next day. He still had a bit in his back, but he was much, much better. So we put him up in hyperextension again, and the back pain completely disappeared. And I thought, this is a wondrous thing that's happened here. I wonder why. And at that time, Brian Mulligan and Brian had purchased Syriax's book. And he says, Matt, you've got to get a copy of this. He says, some great stuff in there. So I went and bought it, Syriax's Volume 1. Read Volume 1, and Brian and I started to meet and swap ideas and talk about manipulation. And Syriax, of course, his whole idea was that pain came on slowly, it's a nucleus. If it came on quickly, it's annulus. But it was the disc primarily at fault. So I started to think about Mr. Smith, and I thought of the disc, and I thought, if you bend forward, the disc has to move backwards, and if you bend backwards, it has to move forward. And perhaps Mr. Smith, laying in extension, pushed the disc away from the nerve, stopped the leg pain. And the details, of course, are lost, but I know that I used to put everyone with those symptoms into hyperextension. And after 2 or 3 years, it became clear, because I started to record things. It became clear, I didn't record them very well, but I did record them. There were 3 responses from this. Patients would get rapidly better, patients would not get better at all, and some would be worse. And some would get better slowly, very slowly, maybe over a couple of weeks. And I started to think about that. And anyway, one thing led to another, and I used the disc model to work out these things. And then one day I realised I'd had 2 patients in succession. One went into hyperextension, got better almost straight away, quite quickly, within half an hour. The next guy, exactly the same symptoms, and he didn't change. Didn't change at all. So I mulled over what was the difference? Well, the difference was that one guy had only had it a week, the other guy had had it 3 months. And I then realised, we've got to get him early, it works. And then, as things evolved, I realised that the longer they've had it, the greater the chances are that adaptive changes, scarring and fibrosis and all that sort of stuff, has altered the ability to make a rapid change. And as a consequence of scar tissue, you can't change it quickly, but you can change it slowly. You can remodel. Then I saw my first sciatica with an adherent nerve root. It took me ages to sort of work out what that might be. And he used to say if he sat in the car with a straight leg, he used to get worse and worse and worse and worse and worse, which is what a lot of people used to say, even if they were fresh. And I thought, what's going on? And then it twigged on me that if it's a bulge and you flex them, they get worse. And they stand up after they've done it, and they're still worse. But if it's an adherent nerve root, they bend forward and it stretches and it hurts, but when they stand up it stops again. So they don't have constant pain, they have intermittent pain. Only when they put it on stretch do they have pain. Whereas the disc bulge, they have pain as long as the nerve's compressed. These little things sort of, I didn't set out to deliberately create a model, but it was the cause and effect were rationally explained if this was what was happening. Of course, there was no proof that any of this was in any way correct. There was no scientific studies that supported any of these ideas. There wasn't then, there is now. So that led to experimentation in all sorts of planes of movement. In the cervical spine, one day I had a lady come in and said, you know, she says, when I brush my hair in the morning, my left arm goes numb. She says, I brush my hair, which way do you do it? And I said, well, do it now, put your head over there like this. And she said, no, my left arm's going, I've got tingling in my fingers. Now put it back. Slowly going, she says, slowly going. I said, put your head over the other way, I don't feel it. Further, do it again. And I realised that the same things, similar things, were happening in the neck, just different movements. And then I had a guy come in one day, and he was a huge lateral shift, right off to one side, couldn't stand up straight. And I thought, now that disc is doing this. He was tilted right away from the side of pain. But if this is a disc, if I push him back the other way, it should change it. Well, the first, I got hold of him and squeezed him, and it's hurting, don't do it. Okay, well, it wasn't right down his leg. He had a big shift in back and buttock. And I started to realise that if you're doing the right thing, it would hurt the middle of the back, and if you're doing the wrong thing, it's get further away, peripheralise rather than centralise. And then I repeated squeezing him over and over again, and then it gradually got straighter and straighter, and the pain went away. And I thought, a sciatic scoliosis is caused by a disc, so they say. Orthopedic surgeons say, so they must be right, of course. This guy hasn't got sciatica, so there's a precursor. This is a sciatica waiting to happen. If I pushed him the wrong way, he'd get worse. And on him, I didn't do it. I left him corrected. And the same guy, a year later, and we caught him on movie. We got a movie of him. That movie I've tried to trace and I can't find it. But it's the first one. This mate of mine cranked the film around, he had an 8mm film. And they kept it running from the time he walked in to the time he walked out. And that guy, I remember that guy's name too, Guy Little. Guy Little was the first patient that I corrected with the lateral shift. And he was on film, which I later showed at a conference in Monte Carlo. Conference of British Association of Manual Medicine. That opened a few doors too. But the whole thing has just been a series of, it seemed to me that out of the blue, an explanation for some of these things would suddenly appear, which was logical. And so I then realised that if you could move the pain to the middle, you're moving the patient in the right direction. It's a prognostic sign. If you move the patient to the middle, the patient's going to get better. He's going to do well. They'll do. And if you can't, they're going to take a long time, or they're going to get worse. And then I found out quite dramatic circumstances when a patient came in and I was squeezing him and I busted his disc. And his back pain stopped and his leg pain became intense, and he had to be. Mortification. He was carried out into an ambulance, and I pushed him too far, too soon, too hard. I gave a real good squeeze. And then I realised that peripheralisation is not a good idea. So if pain centralises, you're moving the patient in the right direction. If it peripheralises, you're moving in the wrong direction. Not just if you move it away from the middle of the back, it's not a good idea either. But anyway, those little refinements came over time. And then I used to call up some of our other physios in various places, and Keith Ritson and I, and Craig Cameron, and Brian Mulligan. We formed a little manipulative group, and we used to meet in Palmerston North every year in the mayoral chambers, of all places. And I used to demonstrate some of these things that I'd found, and I used to say, if pain is here, you do this, and if your pain is there, you do that, and it moves to the middle. And those early days, the word got round from one guy to another, and so Mark Laslett came down from Auckland one time. This is a long time ago, and he spent 2 weeks with me, observing in the clinic. And by this time I had been lecturing that there are 3 syndromes: derangement syndrome, which is internal derangement with disc; a dysfunction syndrome where scarring is inhibiting movement, or adaptive shortening is inhibiting movement, it has to be remodeled; and the postural syndrome where patients sit for long periods in a bad position, they get pain. And 3 syndromes are identifiable. And I was explaining this to Mark. Well, I became extremely disturbed when Mark Laslett went back to Auckland and wrote in a local medical newsletter that he had said that he could identify 3 syndromes. He could identify 3 syndromes in back pain: derangement, dysfunction and posture. Didn't give any credit to where the ideas came from. But I've never forgotten that, and I forgave him, but he's repeated similar things since.